Hello, my name is Jennifer Sims-Mourtada, and I'm the lead scientist in the Cawley Center for Translational Cancer Research, located at the Helen F. Graham Cancer Center and Research Institute. I also direct the Translational Breast Cancer Research Program at the Graham Center, and I'm very excited to be here today to tell you about some of the exciting work that we're doing within the program. Our breast cancer program has really two main areas of research focus. The first is improving breast cancer prevention strategies and diagnostics, which I'll talk to you about today. The second is improving treatment and outcomes for women with triple-negative or metastatic breast cancers. I don't have time to talk about this today, but it is an active area of our research. So as most of you know or are well aware, breast cancer is the most common cancer in women and second for cancer-related mortality in women. And we do have a really good breast cancer diagnostic, screening mammography, which really does reduce breast cancer mortality. But we can do better. And studies have shown that the positive predictive value of mammography is only about 30 to 40%. This means that about 60 to 70% of lesions that are seen on mammography are really benign, and this is resulting in unnecessary biopsies and a huge healthcare cost. Moreover, sometimes mammography can be hard to interpret in certain women, such as women with dense breasts and young women. These women often have a false negative rate of 5 to 10%, meaning that their lesions are really not seen on mammography, and this is important particularly for younger women, which we know that the rate of breast cancer incidence is increasing in this population. Additionally, about 18 to 20% of triple-negative breast cancers are not seen on mammography. This is because they appear as inter-interval cancers, so they're not big enough at the time of mammography for mammograms to detect them, and they also lack certain characteristics such as calcifications, which we rely on to detect lesions in mammography. Another problem with mammography is that screening mammograms can detect very slow-growing lesions that really will never be clinically evident. And by this, I'm talking about ductal carcinoma in situ. And we know that the incidence of DCIS has increased about 500% since we started screening mammography, and it's predicted to increase even more with more sensitive screenings. But only about 30 to 50% of these will progress to invasive cancer, and we really don't know which ones. We really want to treat the ones that are going to progress, but we have to treat them all. So we're really obligated to treat because we cannot say which women will progress and which women won't. So everyone who has DCIS will go through treatment, including lumpectomy, radiation, treatment with aromatase inhibitors, and sometimes mastectomy. And this is estimated to have a healthcare cost associated with it with $4 billion of overtreatment, plus unnecessary side effects and psychological stress that women go through when they're exposed to breast cancer treatment and they really don't need it. So we wanted to see, can we develop a blood test to detect invasive breast cancers? We're not the only ones to do this. There have been several tests that have come before us. You've probably heard of some of these tests. One is looking at circulating tumor cells, and this tries to diagnose breast cancer or other cancers by looking at tumor cells that leave the tumor site and enter the bloodstream. However, these really aren't found in early-stage breast cancers and really won't help us with detecting early-stage breast cancers. It's also very cumbersome to isolate these cells, and you need large amounts of blood to do this. Similarly, a second way of detecting cancer is looking at circulating tumor DNA. And this is because as tumor cells grow, a large amount of tumor cells die and they shed their DNA. But it's really unclear if the circulating tumor DNA really represents a viable breast cancer cell. Again, just like circulating tumor cells, you need large amounts of blood, and it's really unclear if circulating tumor DNA is present in early-stage breast cancer. So we wanted to take a different approach to diagnosing breast cancer, and we decided to look at immune response as a biomarker of breast cancer. So we know that tumors are sites of chronic inflammation. This was discovered back in the 1800s, where they were described as wounds that do not heal. We know that immune cells, different types of immune cells, are often found in breast cancers, and they come and go throughout the breast cancer. And we know that activated immune cells can kill tumors, but this doesn't really happen when you have invasive tumors. So why doesn't the immune system eliminate breast cancer? This is because the immune system is actually changed by the tumor cells as the tumor grows. This is a process known as tumor immunoediting. It has three phases: elimination, equilibrium, and escape. During the elimination phase, if you have an abnormal cell, the immune cells are able to kill this abnormal cell and clear the tumor so that you would never know that you had an abnormality. In the equilibrium phase, some cells develop mutations that cause them to divide very rapidly, and they're not able to be kept in check by the immune system. So while the immune system can still kill some of these cells, it's not as efficient as killing, and a lesion will form, but it doesn't really progress. In the escape phase, tumor cells begin to grow so much that they can no longer be killed by immune cells, but they also modify the immune cells themselves so that the immune cells no longer attack them. They also modify the immune cells so that they secrete growth factors that actually cause the tumor to grow more and become invasive. So we wanted to see, can we track changes in immune cells to predict tumor growth? So the way we wanted to track changes in immune cells is by looking at their epigenetics. Epigenetics, or methylation patterns, are chemical modifications in DNA that change the way genes are expressed. We know that epigenetics controls expression of genes involved in immune escape. These changes are induced by chronic inflammation that occurs in tumor microenvironment, but not by acute inflammation that's caused by infection. And we thought that this may be a way for us to track, by looking at the immune cells, which ones have been affected by the tumor and which ones have not been, therefore allowing us to determine what is the breast cancer risk of this lesion. So to look at differences in epigenetic profiles in immune cells from women with and without breast cancer, we used a machine learning diagnostic approach to determine which of these sites might be different between women with cancer and women without cancer. To do this, we collaborated with a company called Genome Profiling that was founded by my collaborator, Dr. Adam Marsh at UD. Dr. Marsh is a marine biologist, and he had developed this platform to determine epigenetic differences in cold water fish that were exposed to different environmental conditions. And he realized that this platform could be used for many different indications, looking at differences in epigenetics. And so we collaborated with him on this breast cancer study. When we compared women with breast cancer to women without breast cancer, we found over 14,000 different sites, 14,000 sites that had different methylation patterns in their immune cells between the two groups. We then narrowed this down to the top 40 sites. This was all done by next generation sequencing. And we were able to predict if a woman had no cancer, invasive breast cancer, or DCIS with about a 70% accuracy. If you remember, mammography only has 30 to 40% accuracy, so we're actually doing a little bit better than mammography. We were also able to predict the risk of DCIS by looking to see if the epigenetic pattern resembled women that did not have breast cancer, or if it resembled women that had invasive breast cancer. And we were able to predict risk based on pathological criteria with about 90% accuracy. These were from our initial studies. We're still refining our studies. And right now we're working to make this a clinical test by changing our next generation sequencing platform, which is very expensive, to a high throughput plate-based platform, which hopefully will be low cost and be able to be done in clinical labs. And we've just received a grant from the state of Delaware to actually do some of this work. Our early work did show that using a signature of 14 different genes now that we've found, we were really able to discriminate immune cells from women that have normal or no evidence of breast cancer versus invasive breast cancer. And then we were able to determine the risk of DCIS, high or low risk of invasiveness, looking at these profiles of invasive and normal. So this is how we think our test will be used. We're not trying to eliminate mammography. This is designed to be a companion to mammography. So if you go in for a mammogram and you get a negative result on mammogram and a negative result on our Epimarker, obviously you have no cancer. But if you have to get a positive result on a mammogram and a positive result with our Epimarker, you'd undergo biopsy. If you have a negative mammogram result or a positive result on our Epimarker, you could undergo other imaging procedures such as MRI. If you have a positive mammogram result and a negative Epimarker, this indicates that maybe your lesion might not be progressive. and it might not ever change over your lifetime. And since this is a blood test and really non-invasive, we're able to monitor you every few months by mammography and by the blood test to see if there's any change before you undergo treatment. Looking at this as a DCIS prognostic, we would also be able to recommend which women would just need to undergo surgical resection, or women that would be in the high-risk category for invasiveness and would need further treatment such as hormonal therapy or radiation therapy. So far I've been talking to you about detecting breast cancers that are already there. But we want to go a little bit farther and really be able to prevent breast cancers. And so we want to think about biomarkers for breast cancers really as being a test, kind of like a cholesterol test, so you can kind of see where your risks lie. And we already know that a lot of risk factors for breast cancer, including obesity, alcohol, a high-fat and high-sugar diet, lack of exercise, smoking. And so we wanted to see, can we develop a blood test that would help you or help women be able to maybe improve their health and lower their breast cancer risk. So we're looking at biomarkers for modifiable risk factors and their impact on the immune cells. And there's lots of different ways we can do this by looking at different inflammatory markers, different metabolites coming from diet and alcohol. And so this is an active area of our research program right now. And I just wanted to talk to you about one of our studies looking at healthy versus unhealthy obesity. So as we know, obesity is a risk factor for breast cancer, but not all obesity is equal. So some women that have BMIs that would put them in the obese category are actually healthier than other women. So when we talk about metabolically healthy obesity, these are women that do not have a risk factor for breast cancer. It's about 20 to 30% of obese persons. They usually have a low level of inflammatory biomarkers, and they have low to moderate abdominal fat. They don't have hypertension or cardiovascular risk factors, and their hormone profiles are usually normal. So these women have limited health risk by being overweight. However, metabolically unhealthy obesity is a risk factor for breast cancer and many other diseases, and this is about 70 to 80% of obese persons. These women have high inflammation levels, high levels of abdominal fat. They often have hypertension, and there's been a few studies that show that they have abnormal hormone profiles. And so we wanted to see, can we really develop a blood test that can tell you if you have healthy or unhealthy obesity? And we've just done a few preliminary studies on this, but we were able to show that we were, by looking at inflammatory biomarkers, we could determine differences in obese women with breast cancer versus non-obese women. And so we're working now to expand this into a larger population of women and hopefully be able to make this not where we're detecting it at the stage where women have breast cancer, but where we can actually see it before these women develop breast cancer. So that's the end of my talk for today. I thank you all for taking your time. And if you would like to participate or learn more about our breast cancer research program, please visit our website listed here at the end of the slide. Thank you very much.